Good afternoon. Today we're going to be discussing, this will be part two of the IV fluids and electrolyte imbalance, which is chapter 39 in your text. This is going to be about initiating the intravenous therapy or initiating IV therapy. And we're going to also discuss some of the nursing interventions that are going to be included in that. It is pretty common for there to be a need for fluid replacement, and directly into the bloodstream is the fastest way, and also for administering IV medications. So there are several advantages to using the IV route. Again, it provides immediate access for fluid and electrolyte maintenance or replacement, and medications given intravenously have a much faster onset and more predictable effects. And thirdly, it provides access for supplemental or TPN or total nutrition replacement, and allows also for the infusion of blood and blood products to increase oxygen carrying capacity and establish normal oncotic pressure. Remember that if somebody is bleeding, IV solutions will only replace fluid. And in that particular case, they need oxygen carrying capacity, which is the hemoglobin in blood. So typically that's why that is given. So IV fluids, remember, no matter what they are given with the same caution and the medication rights that you were taught previously. So the right patient, again, we always use the two patient identifiers, such as the patient's name and of course their date of birth. And the right solution in this case, which would be the medication, there are several IV solutions with similar names, like 0.45 normal saline and 0.9% saline. So there's different percentages, or you could have D5.5 NS with 20 a K or 10 a K. So we need to make sure that the right solution is infusing according to the doctor's orders. So the right rate with IV fluids is basically the dose part of the rights of medication administration. And so we have to verify that the IV is infusing at the ordered rate. The right route, certain IV fluids, such as TPN, are too hypertonic to be administered through a peripheral site, for example. And then the right time, the IV, if it is infusing correctly, should finish at a designated time. And back in the older days, we used to do a time tape, which I'll show you a picture of that later, but basically it's a piece of tape attached to a bag with the hourly rate decreasing starting at the 1,000 milliliter mark and going down. That's how we would keep track if we were using the drop factor to make sure that it's not infusing too quickly, which can lead to hypervolemia. Whereas other IVs that are infusing too slowly, that basically means that the patient's not receiving the prescribed amount of fluid. And then the right documentation with IVs, we always document the therapy, and we continue to do that as long as the IV is infusing. And it would include things like the IV site, where it's at, what the solution is, the rate it is going, and how the patient is tolerating the therapy. So isotonic solutions remain inside the vessels, where it is about 250 to 375 milliosmoles of oncotic pressure. And as a result, they're useful for clients with things such as hypotension or hypovolemia. Clients that are at risk for fluid volume excess must be closely monitored when they receive isotonic fluid replacement, because they may easily develop fluid overload. And the isotonic solutions most commonly used would be 0.9% sodium chloride, or LR, which is lactated ringers. And basically they have the same solute mix as our blood. So fluid doesn't move in or out of the cells. It stays just in the plasma and where the cells are floating around. The osmolarity of a hypotonic solution is less than that of serum, and therefore when we infuse that, these solutions pull body water from the intravascular compartment into the interstitial fluid compartment. And hypotonic solution is used to correct cellular dehydration. So we want to make sure, if you're thinking about it, that if that is occurring, we never want to give a hypotonic solution to a patient who's at risk for, say, intracranial pressure, because it can cause or exacerbate cerebral edema, which is a big deal. Some of those solutions are like 0.45 normal saline or 0.33 normal saline, are just some examples. The osmolarity of a hypertonic solution is higher than that of our serum. And when that is administered, they pull fluid and electrolytes from the intracellular and interstitial compartments into the intravascular compartment. And so hypertonic solutions can be used to stabilize blood pressure. They can increase urinary output, and it can reduce third spacing or edema. I encourage you to review some of that on page 1480 in your text in chapter 39, and it kind of shows further details and more pictures. So peripheral vascular access devices, which is basically intravenous therapy, requires placement of a vascular access device. So you'll choose the type of device based on the client's condition, the type of fluid that will be infused, and the anticipated length of treatment. And now, having said that, I'm going to go through some different types of the devices, and then I will also have a few pictures for that as well. And these are also some pictures in your book as well. So the most common probably is the over-the-needle catheter, which are also called angiocatheters, or you may also hear them abbreviated as angiocaths. And that is when a polyurethane or a Teflon catheter is basically slid over a metal needle. And you pierce the skin and the vein with the needle, and you advance the catheter into the vein and remove, or in some equipment, you retract it by hitting a button, and the metal needle gets retracted out of the angiocath. And in most cases, the plastic catheter that's left in there is less than 7.5 centimeters, or that's about 3 inches in length. So this type of access device is ideal for brief therapy. You cannot give highly irritating hyperosmolar solutions through this type of catheter because it can cause severe damage to the vein. And there are other medications that are also very irritating to the veins, and therefore maybe a central line might be better. So less common is the inside needle catheter, which are similar to the over-the-needle catheter. However, the polyurethane or Teflon catheter lies inside the metal needle, and then after the catheter goes into the vein, then you withdraw the needle. There's also something out there you may hear called a butterfly needle, which are also called scalp vein needles or wing-tipped catheters. And it is typically a short beveled needle, and it's got two flexible flaps on either side that attach to the needle. And so you can pinch the flaps and hold them tightly together to facilitate insertion. And then after insertion, you flatten those out and you tape them against the skin to prevent dislodgement during infusion processes. These needles are commonly used for intermittent or pretty short-term therapy for children and infants, or for a single dose medication, and they're also very commonly used for drawing blood. Because the inflexible needle remains in the vein, a butterfly needle is more likely than a plastic catheter to infiltrate. And when something else infiltrates, which we'll talk about later, it's basically damage to the vein and allows the fluid to leak out into the interstitial places, so you get some swelling and some pain there. The following are a couple of the pictures of what we just talked about. So as you can see the difference there between those two. Rarely do I see B. Most of them are an over-the-needle catheter or an angiocath. Here's an example of the placement. Going in at approximately a 45-degree angle, you got to puncture the skin and then puncture the vein, and then you should get a flashback in your hub, go about, I don't know, 2 millimeters more, and then advance the catheter and withdraw the needle, and make sure you undo the tourniquet. This person is showing them starting it in the AC, which will, the antecubital fossa. So what we'll talk about later is that for us, whenever we are starting IVs, we should always start distally, looking for a vein, and move up, because if we do miss, and we miss up there, it's hard to go back to a vein down below and not know that it doesn't communicate to one of the other veins up there. So you should always start distally if at all possible. Now, in emergency situations where maybe the patient is not doing well and they're flat, they may not have any veins in those areas, and the AC may be the first place that you go. This is what I talked about earlier, the butterfly needle or scalp needle. And again, it is pretty handy for drawing blood. For whatever reason, I just felt a little bit better with that. And after I got the vein, I could see blood go up in here, and then I would hook that to a vacutainer and draw blood that way. Here's an example of how you pinch the butterfly needle together, and then if you got in there, those two wing tips will flap down. They're just plastic, and then you can tape them onto the patient. So there are also midline peripheral catheters, or we'll call them VADs, or venous access devices, and are flexible IV catheters, and they are typically inserted into the antecubital fossa and then advanced into larger vessels of the upper arm for greater hemodilution, and that would be specific for maybe medicines that are harsh to smaller veins. So the more blood that we can have to dilute the medications, the less irritating it'll be. It can also be used for a longer period of time than the other shorter over-the-needle catheters. These can typically can stay in place for 1 to 4 weeks. A midline catheter is still considered a peripheral line, so you cannot administer high osmolar or irritating solutions through it. The peripheral intravenous locks is the other thing, or we call them saline locks now. They used to be called a heparin lock. And they are kind of a PRN adapter. So you establish the venous return, and these are typically for patients whose conditions may change rapidly, or who may require intermittent infusion therapy. For example, I get Remicade infusion, so every time I go in, I get a hep lock, or the saline lock, which is a little hub that goes on there, and they can put the IV tubing. It comes on and off rather easily. A peripheral IV catheter, or butterfly wingtip catheter, is inserted into a vein, and then the hub is capped with a lock port. And then patency of that lock is maintained by injecting normal saline or dilute heparin. Those have to be flushed every shift or every so often to make sure that they are still working. Most people have heard of a PICC line, and these lines are inserted into a major vein, and they are typically the subclavian or the interjugular vein are the ones that are most commonly used. A PICC line are long, and they're soft, flexible catheters that are inserted at the antecubital fossa through the basilic vein or the cephalic vein of the arm. And then the catheter is advanced into the superior vena cava, and only a qualified person can perform this. So a normal nurse who doesn't have training this cannot insert a PICC line. And PICC lines are most commonly used for prolonged IV antibiotic therapy, or the parenteral nutrition that we talked about later, previously, and chemotherapy. We also have non-tunneled central venous catheters, which are inserted by typically a doctor. It goes through the skin into the jugular or the subclavian, and occasionally the femoral veins. They are sutured in place, and these are often referred to as single, double, or triple, quadruple lumen catheters. So they can have anywhere from 1 to 4 different ports on it, depending on the number of ports that are made by the manufacturer. There are tunneled central venous catheters that are inserted by a surgeon into the subcutaneous tunnel in the chest wall, and then into the jugular or subclavian vein. and then one end of the catheter comes out through the skin and is sutured in place. With the sutures removed when fibrosis has developed around the catheter, or it can be secured with an IV securing device. CVCs are tunneled through the skin rather than through a vein, and therefore have a lower risk of infection because they're further away from the insertion site. There's imported ports, are devices made of radiopeg silicone catheter or a plastic stainless steel injection port with basically a self-sealing silicone rubber septum. So the catheter enters the interjugular vein in the neck, and it may be tunneled or untunneled to a completely implanted subcutaneous reservoir. Those are typically located in the upper chest. Interosseous devices are something that you will probably rarely see unless you work in a pre-hospital or emergency room department. They are designed for immediate access, like within seconds. It's very quick. It's short-term use. We only use them for probably, hopefully, less than 24 hours. The interosseous or the IO device are used to administer fluids when a peripheral catheter cannot be inserted or when a central line insertion is not advisable. So, like I said, it's typically in emergency situations only. And IOs are placed into a matrix of bone, and the venous synoids in the matrix can quickly absorb fluids to send central circulation. The most common access for these interosseous devices are in the proximal tibia in both children and adults, and the sternum and the head of the humerus can also be used in adults. One last thing that's available are subcutaneous infusions, which are an alternate method to administering medications, continuous fluids, or nutrition. They have been widely used in home-based therapy with palliative care patients. And the advantages of the subcutaneous infusions are, number one, they're low cost, and they're pretty easy to use, and they have a fairly low infection and complication rate. So now we're going to talk a little bit about the different types of intravenous fluids. Crystalloids, remember, that are just solutions with small molecules, usually electrolytes, and they are able to pass through cell membranes. So these fluids are really primarily used for fluid and or electrolyte maintenance and replacement. Crystalloids, on the other hand, are further divided into categories based on the tonicity of the fluid compared to normal blood plasma. So we talked a little bit before about the hypotonic, isotonic, and hypertonic. So the tonicity of blood plasma is approximately 290 milliosmoles per liter. And IV solutions with a tonicity significantly less than 290 are considered hypotonic. So hypotonic fluids lower the osmolarity of the blood plasma and cause the fluid to shift into the cells. And these fluids are used to treat hypernatremia or severe dehydration. So continued use of hypotonic fluids can lead to intracellular swelling or water intoxication. And the subsequent swelling of the brain cells will cause the increased intracranial pressure, as I mentioned before. Isotonic solutions have a tonicity that is essentially the same as blood plasma. And so these types of fluids increase intravascular volume only, but do not cause fluids to shift in or out of the cell. When not monitored closely, isotonic fluids can lead to circulatory overload. And we briefly discussed those previously. I'm just reiterating. Hypertonic fluids have a tonicity that is markedly higher than 290 milliosmoles per liter. And these solutions increase the osmotic pressure of the plasma and basically force fluids to move out of the cell and into the bloodstream. And this can lead to cellular dehydration and circulatory overload. So which IVs do we use then? Well, the choice of IV fluids is based on the purpose of the therapy and can contain any or all the following substances. Glucose is in the form of dextrose, sodium bicarbonate, and chloride. So dextrose is a common element of IV solutions and can provide additional calories for energy. It is usually ordered in 5% or 10% concentrations. An IV solution of 5% dextrose in water is an isotonic solution before it enters the body. The dextrose is quickly broken down, leaving a hypotonic solution circulating. Saline solutions, on the other hand, contain sodium and chloride in varying amounts, and normal saline consists of zero 0.9 sodium chloride, or NaCl, and is considered isotonic. And normal saline is used for replacement of fluid, sodium, and chloride. And it is the only fluid used to begin or finish a blood transfusion. And you will be taught blood transfusion later, but do know that it can only be infused or transfused using 0.9 normal saline. Saline solutions vary based on the amount of sodium chloride, ranging from 0.33 normal saline to 3% normal saline, although I haven't seen much of those. It's usually D5.5 NS with 20 K, or D5.5 normal saline, or something to that nature. So it is important to remember that this combination solutions are really considered to be hypertonic. And then LR, which we talked about earlier, it's isotonic, and it is a solution that does contain sodium, potassium, calcium chloride, and lactate, which metabolizes to bicarbonate and most closely resembles blood plasma. So it is considered a balanced electrolyte solution and is often used following surgery, or in surgery for that matter, and also trauma. Some other examples of colloids include albumin, dextran, plasmate, and hetastarch. Blood and blood components are also considered colloids and will be discussed later. So now, what size of angiocath do we put in? So as you can see here, the intravenous catheters come in several different types and sizes. IV catheters are sized by the diameter of the needle, which is referred to as the gauge. And as you can see from the chart, the smaller the diameter, the larger the gauge. So for example, a 16 gauge needle has a larger diameter than a 24 gauge needle. So a 24 gauge needle is pretty small, and a 16 gauge is pretty big. So, 18 to 21s, you also got to consider based on what the therapy is. So as you can see from here, from blood transfusions, we can use anything from a 16 gauge to a 22 gauge, but nothing smaller, because it's said that it will lyse the blood cells if we don't put in a big enough IV. So it's important to consider all that before you stick a patient, to try to make sure what the overall therapy is going to be and maybe how long that therapy is going to be for. So peripheral sites are used when IV therapy will be typically short-term or intermittent, for example, through the use of an intermittent infusion device, or it's an IID, which is capped over the venous device. And so this provides IV access for intermittent infusions or emergency medications. And these devices are often called saline locks or PRN adapters, which I've mentioned before. Selecting the most distal site for venipuncture preserves the more proximal sites for future insertions. So we want to avoid areas at the wrist and the elbow. Obviously, flexion of those joints may obstruct flow, and you're just going to have a pump beeping all the time. So venipuncture is contraindicated on an extremity that has been compromised due to surgery. A good example of that would be like a mastectomy or something like that, where you don't start an IV on that side of where the mastectomy was, or if they were injured or burned, or if there is a dialysis graft in place, you wouldn't want to start an IV on that side either. The condition of the vein is, you've got to look at the vein. I say don't poke what you can see, always feel it. So the vein of choice should feel soft and full, and it most likely is splinted by a bone, and it's easily palpated when you put on a tourniquet. You should see those swell up. The only thing is that if someone's really dehydrated or in a significantly young pediatric population, or the very, very old, those become issues. But they have also came out with new things like vein finders and things like that that are available, that if we nurses can't get the IV inserted, perhaps anesthesia could come and assist and maybe bring one of their little vein finders. Finally, the purpose of IV therapy influences vein selection. So we talked about the large veins are used when large amounts of fluids need to be infused rapidly, or if those fluids are have a high viscosity, such as packed red blood cells. Hypertonic fluids and caustic or irritating medications, when administering through a larger vein, are less likely to cause phlebitis, and that's when the vein gets inflamed and irritated and causes pain and discomfort to the patient. This is just a picture of some of the veins that are commonly used during IV insertion, and this is just of the hand and the arm. So remember that IV therapy is considered an invasive procedure. So a needle entering and resting in a blood vessel, as with any invasive procedures, the risk of infection is increased. So we need to make sure that we use very careful aseptic technique, whether you're using an alcohol swab or a chlorhexidine wipe, either one. With a alcohol wipe, you must wipe from your intended site from inside to out. With the chlorhexidine, you can scrub a general area for 15 to 20 seconds. So some of the complications that are associated with IV therapy include obviously occlusion, which causes our pumps to beep, but also phlebitis, which I said is inflammation of the vein, infiltration, which is just when the fluid leaks out, and extravasation, however, is when a toxic substance, a medication or something, leaks out of the IV and into the tissue, which causes cell death. So when we talked about picking the right rate and the right fluids, we should always remember that there are complications that include fluid overload, which is if something went in too fast, or speed shock, and or embolism. So when caring for a patient receiving IV fluids, medications, and or both, there are several key nursing assessments and interventions to ensure safe, effective care. When initially reviewing the patient information, it's important to take note of the IV therapy currently ordered, and this would include the type of catheter, the date of insertion, and the solution type, and of course the rate, which I mentioned earlier. Note that when the current solution bag was started, that's important because it will kind of help you know when you're going to need another bag. And this will indicate when the next IV solution should be ready. A good rule of thumb is to have a new bag ready to hang when there is about an hour's worth of fluid left in the bag currently infusing. So when you set the volume to be infused, I would set it to 100 less than however amount you're infusing out of a 1,000 milliliter bag, so that the alarm will go off and remind you to get another IV bag solution. If a dressing is soiled, wet, or loose, it should be changed immediately. And for peripheral IVs, and this is generally speaking, the site is rotated approximately every 72 to 96 hours to prevent catheter-related complications. In some instances where it is a difficult, what we call a difficult stick, or they were a hard person to start an IV on, it may be possible that you could ask for a extension for that particular IV, maybe for just one day. So it'll be important for you to check whatever agency policies you have for specific protocols regarding that once you start working. And generally speaking, the tubing is changed every 24 hours. And I always just try to put this in a little chart for quick review. So you should know how often that an IV solution needs to be changed, or how long the tubing should be for, and etc. As always, nurses have to document, so we have to document the appropriate nursing actions. These are just some of the things that you would document. And there are different documentation tools that are available. An example of an IV MAR or an IV teaching and documentation tool. Right here you can kind of see a lot of it is you just click on the appropriate box to document your infusion therapy. So I just wanted to show you what that looks like. Now on to the scary part, right? So how do you compute all that? A lot of times the IV, once it's put into therapy, nurses are typically the first ones to know about it. So instead of just using a smart pump, there are ways around this in terms of what you can put in the infusion rate and the volume to be infused, and on the pump it'll automatically come up with the hourly rate. You got to remember that you're in nursing school and you should know how to do this. So this is a kind of right out of your book type of thing. So, and this is on page 1486. So you should be able to do this. Now, the drop rates that we talk about, the drop factor, those are located on each of your primary, or actually in any IV tubing should have a drop factor on it, because it is used to calculate things like this. So the first thing you need to do is figure out what the hourly rate is supposed to be, and then you times that times the drop factor and divide it by 60, which will give us our drip rate. And the drip rate would be 25 drops per minute in this instance, and therefore we would have to count for maybe 15 seconds to get our roller clamp or the pump clamp to get that there are 25 drops in that chamber every minute. So you can start out by counting it for 15 minutes and then timesing it times 4 if you'd like. That's fine. That'll get you in the ballpark, but then you should count it for a whole entire minute to make sure that it is correct. Now, for infusion times that are less than 60, for whatever reason, sometimes that causes a little angst, but here's the trick. So if your infusion time is less than 60 minutes, you want to divide that infusion time by 60 and then times the volume to be infused. So if I was going to tell you to infuse a 100 milliliter bag over 15 minutes, how would you figure that out? Well, I divide 15 into 60, which is 4, and 4 times the 100 milliliters that are in the bag. So that would be a hourly rate of 400 milliliters per hour to get that in. Now, you also should be doing and reviewing dosage 360 assignment, which will also go through this in more detail. And obviously, if you're having difficulty or need help, ask the question and I can come and help you.